All right, so to finish out the evening, we have a couple of speakers who are going to be joining us here this evening. And the first one, we have Dr. Laurel Stachel and Brent Moellenberg. And Dr. Laurel Stachel is a co-founder and executive director of We Care Solar, a nonprofit organization that designs and delivers solar-powered solutions to health centers to improve maternal and newborn health outcomes. Her husband, Dr. Hal Aronson, designed the first solar suitcase for the Nigerian healthcare in 2009. And she is a gynecologist with 14 years of clinical experience. Now, Brent, who will be joining her, I believe Brent is a colleague, is a mechanical engineer originally from Colorado, now living and working in San Francisco. And he's been traveling to work with PV power systems. Say that 10 times fast, I dare you. In developing countries since 2005, and has designed and installed off-grid systems in some of the most remote areas through Africa and Haiti. So we'd like to welcome both of them to come to the stage. We need another mic for them.
You need another mic?
Yeah, if you would grab another mic. Yeah. Would we like what?
How do I advance?
There's two things.
Computer?
You can do that.
There's that clicker? Oh, there is a clicker.
There is a clicker. And we have a couple microphones, or we can wire one of you up as well.
Okay. Can you hear me? Okay. Thanks so much for having me here. Actually, IEEE has played a really important role in We Care Solar's life. As mentioned, I'm actually an obstetrician gynecologist, so probably not your typical speaker at an IEEE conference. But about 5 years ago, I was actually invited to speak in Washington at an IEEE Humanitarian Technology Challenge conference. And it was the very first time that we had really talked publicly about our work, and that really led to getting a lot of publicity that ended up really helping to really multiply the impact that we were able to have over time. And what I would like to do is really take you on a bit of a journey, the journey that I started in about 2008, and is a journey that's still continuing. And it was really fitting to hear Ben's talk, because he was really talking about the same problem that we're trying to address, although we're specifically trying to look at it from the angle of healthcare. So I want you to start by just imagining something. Imagine right now you're one of the 15 million women who develop a pregnancy complication this year. But don't imagine that you're in a developed country, or that you're in the Bay Area, but that you're in a small village in northern Nigeria, that you have not had any prenatal care, and that you're in labor. But you realize after being on a dirt floor for about 2 days that something's really wrong with what's happening with your labor. And you ask family members if they can bring you to a hospital. And even though they make less than $2 a day, they struggle to pull together the resources to get you to the nearest hospital. And after an arduous journey, you arrive at a hospital, bang on the door, and a midwife opens it, lets you in, immediately recognizes something's critically wrong. She tries to find out if your baby is still alive. She tries to understand why you're bleeding as heavily as you are. And she tries to locate a physician who can perform a C-section to save your life. Yet this is the only light available in the hospital. This is the grim reality around the world in hundreds and thousands of health facilities. It's part of the reason why women like these in northern Nigeria, actually in sub-Saharan Africa, face a 1 in 23 chance of dying during their reproductive years. And they're not dying from rare diseases. They're actually dying from things that I treated for years as an obstetrician in this country, but I never associated it with mortality until I spent time actually watching what was happening in some of these hospitals. Part of the reason that these women are dying is that they have not had good access to care, that they haven't had good education, that they're obviously in very impoverished families. But part of the problem lies in the health facilities themselves, where even when people come to a hospital, they may fail to get the care they need. This is the surgical ward of a hospital that I spent quite a lot of time with in northern Nigeria. You're actually able to see that there's grid electricity lines, and behind the operating theater there's actually a generator. A small generator. But even though the hospital supposedly had access to electricity, it was actually in darkness about 12 hours of each day. I spent 10 to 14 hours just observing care on a project that was basically designed to try and allow Americans and Nigerians to work together to try and lower rates of maternal mortality. So I was asked to spend time just watching what was happening inside this hospital, and most of my time was spent in this room. This is the ward of the hospital, and you'll see this is labor and delivery. I'm sure if any of you had been in a labor and delivery in the United States, you'll know that it's a far cry from what we're really accustomed to. There were 4 beds on the right side, all metal tables, no mattresses, no pillows, no monitors, no bright lights, no privacy, none of the things that I had been accustomed to in this country. Yet most of the women who arrived here were suffering from some of the worst complications I'd ever seen, because most of the women were trying to deliver at home, and only the ones who had complications would actually make it to the hospital. If you turned your direction away from the tables that I was just showing you to the other side of that room, you'd see the water. And don't look at the sink, because if you look closely, you'll see that that's actually disconnected. It's the bucket there that has the only water that was available for labor and delivery, and a very similar situation existed in the operating theater. The lack of reliable electricity meant that there was no way to sterilize equipment regularly, and so they used a series of buckets of different concentrations of bleach solution in an effort to try and sterilize equipment. Yet they didn't have a lot of equipment, so very often the equipment would not actually make it through all 4 of those buckets before being used on the next patient. The lack of reliable electricity meant that surgeons tried their best to do surgery by the ambient light of windows. You can see that there's no operating room light that's actually functional in that room. The same was true for the suction machine that couldn't be used, and a cautery device that couldn't be used. And when I was there observing at night, when the lights went out, literally they had to use my flashlight to finish a C-section. The electricity deficiency also meant that there was a lot of equipment that couldn't be used. So here was a beautiful ultrasound machine that laid completely dormant in a closet because there wasn't electricity to power it. This machine used about 400 watts of electricity, and it was in sparkling good condition. And on one occasion, when I knew a patient needed an ultrasound, I had to pay $25 to someone to turn on the generator for 5 minutes just so that I could get this ultrasound to be able to function. The other issue was that there was no way to actually refrigerate blood, because all they could use was a domestic refrigerator. They didn't have the power for a blood bank refrigerator. So if someone came in needing a transfusion, they had to bring with them a family member who was then tested to see if they had a similar blood type, and then tested for infections before they could actually get a life-saving transfusion. It also meant there wasn't a good communication system. Now, this was 2008, and at that time they didn't have a very good cell phone network. So instead, if somebody needed emergency care, like this woman who was bleeding from a condition called placenta previa, the placenta was actually in front of the birth canal, she was bleeding, and she needed an emergency C-section. The only way to get a doctor was to ask a messenger to go looking through the hospital compound and then around the hospital to see if they could find a doctor who could be brought to the hospital to attend to her care, and then to do the same thing for anyone else in the operating room, such as someone to provide anesthesia or an operating room nurse. In this case, I was observing, and after 4 hours, I couldn't stand it because no one had come. So I went myself banging on doors until I could find someone to come and help. And by the time we got back, she had lost her baby. And I saw situations like that repeatedly in the first 2 weeks I was there. And at nighttime, when the power was down, this is what the maternity ward looked like. Now, in this room, there's actually 12 mothers, 12 babies, and family members. You can't see them, and neither can this nurse. Yet this is what she was expected to do. And let me tell you, this is in a city with 1.5 million people. This is a state hospital, and they were doing 150 deliveries every month. And they would lose about 3 to 8 mothers in that hospital every month. Now, what I've just shared with you was some of the things that I had seen in those first 2 weeks in northern Nigeria, and it was pretty overwhelming. And I had never realized before I had gone to Nigeria that electricity could be such a fundamental, essential ingredient of emergency obstetric care. So I really was thinking about all the things that I had seen, and at the time I was writing emails back to my husband, Hal Aronson, who himself was basically creating educational programs for students in California about solar energy. And I shared with him some of the stories I just shared with you. And he said, look, when you come back, Laura, maybe we can do something to help this hospital. We can't really fix everything, but at least I could help you to design a solar electric system where we could really address the issues that you were talking about with light and mobile communication. So we came back and we actually started an organization called We Care Solar. We Care is an acronym. It stands for Women's Emergency Communication and Reliable Electricity. And Hal's idea was that we would design off-grid solar electric systems that could address the essential elements of maternal health care. And so he designed 4 solar electricity systems. One was for the operating room, one was for the labor ward, one was for the maternity ward, and one was for the laboratory for a blood bank refrigerator. And he wanted something that was easy to maintain and that would use very high efficiency appliances. So at that time, fluorescent lights were seen as more efficient than incandescent lights, and LED lights were pretty new, but we included them in the system thinking they might be inferior, but at least a good backup system because they were so highly efficient. We also tried to think about how we could improve communication and brought in walkie-talkies that were using DC electricity. And then in the operating room, we brought in an inverter so that we'd have AC power to be able to use the suction machine and the cautery devices I showed you before. Now, my idea was that I'd bring my husband back to Nigeria and that he would actually teach people about solar electricity. He actually saw the same photographs you saw, and he said, no, Laura, you're going to have to teach them. And I said, look, this is too much for me. I'm an obstetrician. I don't understand. So he let me take one of his classes, and I still didn't really feel like I had a good grasp. I said, you're going to need to make something for me, a demonstration kit that's really easy to use. So he took all the elements you saw on the diagram before, things like a charge controller and solar panels and a battery, and he basically tried to make a very simple unit that he attached to a wooden board. And I said, you need to make me something small enough that I can get through customs in the airport. So he literally made something that would fit in my suitcase, and this was him designing it, and this was me opening this up and sharing it with some of the doctors in the hospital in Nigeria. And they actually loved the demonstration kit. And I said, well, I'm going to be bringing you a much bigger system. I actually interviewed people in Nigeria who could come and do the installation. And this particular operating room nurse said, you know what, this could help us save lives right now. Please leave the demonstration kit here. And so that's what we did. You can see the walkie-talkies that are there. We actually left the demonstration kit while I went off to try and fundraise and pull together this larger system. So in the meantime, it was used to power headlamps so that nurses could now start IVs at night. It was powering the walkie-talkies. And the thing that we hadn't realized was that even a 5-watt bulb, an LED bulb, was enough to do a surgery at night. Now, I came back several months later. We did the larger installation that we planned. The maternity ward went from looking like this to this. The operating room went from looking like this at night to this. We did bring in a blood bank refrigerator. And over the next year, the maternal death rate inside the hospital went down by 70%. And the hospital was no longer turning away women at night when the lights were down. And by the way, the story I shared with you where I said, imagine you're a woman, that was something I really witnessed. And I actually also witnessed them turning people away at night when the lights were down. Honestly, I thought we were done. At the time, I was actually studying public health at UC Berkeley, and my idea was to work on a dissertation trying to describe what it was like for health workers to work in areas with poor resources. But other people had something else in mind. People from surrounding clinics knew that the big hospital got electricity, and they came to me and said, why are you only helping the big hospital? We're actually delivering patients in the dark as well. Can't you help us? Now, that first system I showed you cost over $20,000 to put in the blood bank refrigerator in these larger systems. But the small compact demonstration kit was a lot cheaper. And so Hal and I began to think that maybe we could just purposely make solar that I could fit in my suitcase each time I was coming back to help each of these clinics. And so that's what we did. We created these suitcase-sized systems. I was continuing with my dissertation work, and each time I would come back and bring one. Well, I went to a global health conference and I spoke to, do y'all know Nicholas Kristof, the writer from the New York Times? He gave a talk that was very inspiring, and I went up to him at the end and I mentioned to him how much he had inspired me, actually. Unbeknownst to me, he ended up writing about it in the New York Times blog. The next day, we got requests from around the world for these suitcase-sized systems. So all of a sudden, we realized the thing that we had recognized as a problem in Nigeria was actually a problem in a lot of countries. And you'll notice on the map that these countries are actually clustered around the equator. Pretty good for solar. So we began sending them out. So all of a sudden, we were sending them to countries that I hadn't been visiting, like this one in Rwanda and another one in Nepal. And then there was the earthquake in Haiti in 2010. And people who had heard about the solar electric suitcase said, well, why can't you send it down to Haiti? And so that's indeed what we did. We took the suitcases that we had designed for Nigeria, sent them to Haiti, but guess what? There were some problems because the way that we had designed it actually didn't really work as well in Haiti. So all of a sudden, I had to think of a way to go down to Haiti and fix some of those problems. Now, at that time, I was on weekly phone calls with the Human Technology Challenge Group from IEEE. And on one of those phone calls, I heard a brilliant lecture by an engineer who was talking about all the failures that he had seen when he had been working in Haiti with Engineers Without Borders. And I'm so delighted to be able to introduce that engineer to you because it's Brent Moellenberg. I met him through IEEE, and I invited him to come down with me to Haiti. So why don't you come up, Brent?
Thanks, Laura. So you'll find where Laura's speeches are inspirational and powerful, my speeches are like a third grade design review. And so I apologize for bringing the mood down. The talk that Laura was speaking of was actually about work that I had been doing with Engineers Without Borders in Haiti. And I'd been working there about 5 years at that time. And I was starting to see problems with some of these larger solar PV systems, the multiple kilowatt PV systems, in that the cost and the complexity and the situation in Haiti made the maintenance of a lot of those systems very difficult. And so when Laura first approached me, I was instantly intrigued about a small DC-only suitcase-sized system. However, I must say I was very skeptical that a small system that only had 40 watts could supply enough power to be useful. I traveled with Laura to Haiti and was very excited to get the opportunity to do that, to both assess the suitcases that were already there that she had sent earlier, as well as we were taking extra suitcases with us to help out with the relief efforts that were going on at that time. We got an excellent opportunity to be in front of a number of people and show these suitcases, and it immediately became clear to me that there was something about these suitcases that people were very excited about. As we went on and worked with more medical experts, it just became so apparent that not only was this 40-watt system with 2 small lights, not only was that light adequate, it was far superior to what they were used to using. And by the end of that trip, I really realized that the first 100 watts of electricity are one of the most important tools that a medical clinic has to use. So we came back to the Bay Area and immediately realized we need to scale up because we were getting requests from all over. But at that point, suitcases were still being made in the backyard of Laura and Hal's house by volunteers, by hand. There was a lot of wood involved. Most of the supplies were actually sourced locally from hardware stores and wherever they could be found. And so because the designs were each custom-made and hand-built, there was no standardization. This was great for customizing for the clinics that got them, but any kind of effort to have a standardized teaching regime or to do any service remotely was nearly impossible. And so we realized we've got to make some changes to this design. So we started putting together a design criteria for this suitcase, and we tried to figure out what are the things that we need, knowing where these are going to end up, and what are the aspects of this that we know users are already so excited about. We knew initially that portable is important. We have to be able to get it out to these sites And often as not, especially in the early days, these were actually going on as carry-on luggage. So then that meant that we had to have the Department of Transportation rules fit into our suitcase as well. So if you want to have a lot of fun, try to take like 20 batteries to Liberia through Delta. The units had to be robust. We knew this. We knew that where they were going to end up, they were going to have a very harsh life in a clinic in the middle of nowhere. But in addition to that, it's not just once they're out there, it's the trip out. And so many times these suitcases would be traveling for days beyond the central city in a country that they were ending up in. And for instance, this is in southwestern Uganda. And when the suitcases, we took, I think it was 12 systems down to this area. And the suitcases which traveled down there traveled for 2 days under a load of sweet potatoes. That was not our plan, but that's the reality. And so we were very thankful that at that point we had chosen this design criteria. Now, the systems also need to be robust. And the robustness I'm talking about now is once they make it to the clinic, they can't fail. We have to have systems that are not hindered by a simple 10-cent part that fails that takes down our entire suitcase. And so all along, we tried to pick the most robust pieces, components that we could, because we knew that if it failed out there, there is no service structure, and especially there is no parts available. What you're looking at right here is the finest hardware store that Zaire, Nigeria can offer, and this is good compared with what we found a lot of places. And so I guess the same way that they say the Native Americans used all parts of the buffalo, in Nigeria they use all parts of the motorcycle. It had to be easy for the users, both for the people who were installing the systems as well as for the people who would be using the systems. We didn't know who the end users would always be, and so because of this, we had to make it so that few extra tools were needed and that almost anyone could intuitively use the system. This is a Maasai warrior who is stripping some wire for us with his machete because that's the tool he has. So the systems had to be adaptable. We did not know what size rooms or clinics these would be going into. It varied greatly. And so as you can see, this clinic it's fairly standard, but within one region you might find that the buildings are fairly standard among themselves. But you go to another country and you might find something like this. And so to have one system and one system only able to meet all of this criteria, that was something that was very important because we knew we would not know what it would look like until we actually got out there. The systems had to be appropriate. Now, by that, what I mean is our first and foremost criteria was we need 2 lights on all night long. So we need a battery that can support that. We need the solar that can put that much energy into the battery. And we need lights that are efficient enough to handle that. In addition, the equipment that's there, we need to have lights which can be used portably, as well as potentially fixed to a ceiling if that's what the users want. A lot of it is personal preference, and so we need to have pieces that can be used in either case. It needs to be dependable. Among all, we knew that these were being used in exam rooms, and we knew that they could be used in surgery. But when you see something like this, and you know that your light is the only one being used in the middle of a surgery, you know it cannot fail, and it must be efficient enough that it does not wear down your battery before that surgery is done. It has to be safe. Luckily, with a 12-volt DC system, electrically, we're in pretty good shape for the safety there. But we can't have anything that has a hot surface, a sharp surface. We obviously have to take great care with batteries that there's no problems caused by that. So that was a very clear criteria as well. It has to be versatile. Now, from early on, we knew that cell phone charging and actually any communications, walkie-talkies, as Laura had said, are very important. But as we've gone on, we can see that cell phones are actually much more important than we've maybe initially thought, because while at first we thought it's more for personal communication, this is often the one and only way that a clinic can get a hold of a regional hospital, or more importantly, a hold of an ambulance who can come out and get a patient who's dying. And so truly, the cell phone charger is a life and death piece of material. And so things like this, we began to see over time that maybe what we knew was sort of important made a lot more sense when you see it in the field. And as we went on and we went to these clinics, we would see that a lot of the users needed more than just the light and the cell phones that we expected. Here you can see a fetoscope that a midwife is using to listen to a fetal heartbeat. As you can imagine, it's just a metal funnel, so it's not exactly accurate, and it's very difficult to use. Knowing that, we now often will include a fetal Doppler, a small fetal Doppler unit that uses rechargeable batteries charged by our system as well. And we started to see these kind of uses more and more. And so we began to understand that what we were providing was more of a power platform because more medical devices could be used with these power sources. So, taking all of that design criteria, we went back and we started making prototypes, as one does. And we would make a prototype, we would bring it into our lab, we'd try to beat it up. If it survived that, then we would take it out to the field. We would do some field tests with it, we would get the feedback, we would come back in, make some changes to our design, roll out another prototype. And we tried that several times. And eventually we ended up with the system that's where we're at right now. So the system pretty much has met our needs. We've got a strong case for the outside, which will let us get it out to the clinic and which will let us permanently mount it to the wall, or they can continue to use it mobily if they'd like. We've got lights, custom-made lights, which are professionally made and which are highly efficient and very, very strong. We've got batteries we've selected. We've got accessories that are both efficient and affordable enough that we can include them in each suitcase. We've got AA and AAA battery chargers that are used to charge batteries for headlamps because the light sometimes needs to go outside of the clinic. We've got, not shown, we've got tools because we realized that you can't count on any tools being available anywhere. So we include screwdrivers and all the screws. Everything necessary to do an installation and to do a good installation is included in the suitcase. In addition, we created a suite of extra pieces, accessories. Here you can see that we've got gooseneck lights for our gooseneck mounts for our lights because we're seeing these lights used in other places that we didn't expect. We've got expansion kits to allow the suitcase to be used in more rooms, and effectively it makes one suitcase act like two if you add a little bit larger battery and some more solar panel. So we drew up a bunch of drawings, did a bunch of documents, found ourselves a contract manufacturer that would actually talk to us. And now, for the first time, we had the ability to turn these out in mass quantity at a quality level that was, for once, really what we were looking for, exactly what we asked for. And so now we could actually scale up. So there's us. There's our product. Throw in some field tests and wrap that back into the product. But at this point, we knew, after seeing in the field and seeing so many broken systems off in the corners of all these clinics, we knew that technology alone is not enough. And so we did not want to be that next group off in the corner. And so this is where we really started concentrating on, we've got to get this training right. We've got to train the users right as well as the installers. Well, that's easy to say, but we need more pieces to be able to do that. So we started working more heavily with partners to bring in partners in country. These are people who would have connections inside the country to the Ministry of Health and would be established in these countries. And then we would work with them to do implementation, maintenance, and monitoring. Initially, we would do all of the trainings ourselves. Here you can see Laura training a group of midwives directly. So even though we try to make the suitcase very simple to use, there just are some training steps that are always necessary, especially with the conservation of energy, because you want to have the lights all night long. Here in Sierra Leone, you can see that not only are we training the midwives, we're actually training half of the community back there because they are really curious about this solar electricity thing as well. And we see that quite a bit. But it's actually great because all of those people are going to go tell people, hey, there's lights down at the clinic, which is a huge thing. You've got to advertise it. You've got to know that it's there to use. Here, a midwife goes on to teach other midwives. So if we can teach the teachers, they can go out, they can check back, they can do refresher courses, as well as they can take the suitcases out to places that we can't reach. We train local capacity as far as technical workers who can install the systems. Now this has a twofold benefit for us. Number one, we feel good about leaving skills locally. But the second thing is this is automatically building in our service infrastructure for if it's needed. We do classroom trainings and certificate programs. And more recently, we started a Solar Ambassador program. In this case, we brought in 14 women from around the US and 4 other countries. Brought them in for a week, did an intensive training about our systems, about solar. Most of them had some background in solar. But taught them not only about our systems, but how to teach our systems. Now, these women have gone on to install systems all around the world. Some of these women have installed over 100 systems. And so that is a great model because it allows us to teach more places than we can travel ourselves. Whenever we go into a community, we try to involve the community heavily because, among other things, it reduces theft. If people feel like the system is theirs, they're less likely to abuse it. And again, it advertises that the system is there. There's an additional component to this, which is if enough people know it and they feel like it's theirs, that puts pressure on local policy makers, politicians, et cetera, so that they are willing to support the system when it's time for a battery to be replaced or time, to take care of the system in routine ways. Some of the partners we work with, we always try to partner with very established groups in these countries, and we try to partner with groups which work through the Ministry of Health rather than subvert it. And so by doing that, we can help strengthen those ministries of health. And in addition, by piggybacking on the work that they're already doing, we can provide the product and technical support to them. And then once we have implemented a project, they remain and they can help us out with the long-term sustainability. In Uganda, we are working with a Saving Lives at Birth initiative for 143 suitcases there. In Malawi, we have 40 systems. We just trained 23 healthcare workers to know how to use our system and then use the rest of the week to go out and install systems alongside them so that they would know how to do that. In the Philippines, we have 100 systems funded by MacArthur Foundation, which are used not only as mobile systems, 10 of them are used as mobile systems, but 90 of those are going into clinics that were most affected by the typhoon. In Ethiopia, we have, I can't remember the number, 35, but I think we're going up to 143. Is that the total? 143 extras for a program there. In Liberia, this was one of our early programs. We had 20 funded by the WHO, and we are just recently sent more to help out with Ebola response teams. So, as our systems grow, you can see we've got over 900 systems implemented in over 27 countries. We've trained over 1,000 healthcare workers on how to use and install our systems. But the biggest challenge still remains.
So really, the biggest challenge does remain, and that's how to keep these there. We sort of figured out how to make something that's robust, how to get it out there. But now we're really figuring out how do we work with these partners to sustain it over time, and that's something that we're doing by looking at different models that we've used to see what's working, looking at other groups, and we'd be very interested in if any of you have input on that. We're actually reviewing models and trying to come up with a new sustainability framework for our organization. And Brent has really shared with you how this has grown. But before we close, I just want to share with you a story of even how one solar suitcase can make a very big difference. This is a story about a doctor who's wearing that orange t-shirt. His name is Dr. Jacques Sibasaho. And he contacted us right before Thanksgiving one year and said, I am desperate to get a solar suitcase. I'm in New York City and I'm about to go back to the DR Congo and there's no electricity in my village. And we actually sent him a solar suitcase overnight and then taught him how to use it by Skype. And I said, please contact me the minute that you get to DR Congo. I want to be able to help you, talk you through this. And I never heard back from him for weeks. And I thought, you know, probably this thing was confiscated when he was trying to get through customs. But he did finally call me, apologizing for the time he took. And he said, the night that I got to the clinic, there was a woman delivering twins, and I used it to deliver her successfully. But the next day, there was an outbreak of cholera. And for the next 30 days, I treated 122 mothers, fathers, and children with this disease. He said in the past, 50% of the patients would die, and 80% of those deaths happened at night. But he said for the first time in the history of our island, nobody died from cholera. He said, we are witnessing what light can do in communities where night means death to those in need of emergency care. That's one village. And I think that you all know that there's a lot more than one villages that could benefit from a small solar electric system. Imagine now a world where each of these clinics actually do get the electricity that they need to save lives. Imagine that women no longer have to wonder when they are pregnant whether they're going to survive to be able to see their child grow. Thank you very much for the opportunity to be here. We Care Solar is really trying to show that it is feasible and practical to get small-scale solar electricity out to last-mile health centers. Brent and I are here to answer questions. I thank you so much for your involvement and your support through the years. And I have one tiny request, which is that we're actually up for something called the Sustainia Award. And if any of you could indulge me, I have actually shamelessly put down 2 ways that you could help. There's a community award, and if you could help and vote for We Care Solar, we're going to Copenhagen in 2 weeks, and we'll see. The person giving out the award is none other than Arnold Schwarzenegger. So, but in any case, I want to thank you, and I actually want to publicly thank Brent, who really never comes and gives talks with me, but this thing would still be on a little wooden board looking like those earlier slides if it wasn't for Brent having joined us. So thank you so much.
And I'd like to thank Ray Larson for connecting Laura and I, because he is actually the one that got us together. So thank you, Ray.
So we have a few minutes for questions before we bring up our next speaker. So does anyone have any questions? Over there. Yes, we'll play Run with the Microphone.
I just wanted to know that, like, which kind of help can we have? Like, I'm an engineer, but I'm concerned about all the world and the problems, and it's very inspiring, the talk, and all I can think is the problems I have in my community too in Brazil. So I really would like to know, how can we make the same things, because we have similar problems there. So if we could try to make something that we can adapt there, I really would love to do, and if there's anything that I can do to help that would be amazing to me.
Thank you. So the question was about how can we help in Brazil, and I actually visited Brazil, and I know that you have electricity lots of places, but there are also places that are off-grid. I think that the ways that you can help are multiple. I mean, certainly there's the opportunity to take We Care Solar products and actually bring them into the field. We're a nonprofit, if I didn't say that already, and we work with foundations and with other types of donors to get these out there. So that's one thing. I didn't also mention that we have a sub-program that's called We Share Solar, which actually is a kit where people can build their own solar suitcases. It's a blue version. We tend to put these in schools and orphanages, but I would think over time it's going to be possible for us to get kits out to communities that would like to build them, but that's not a program that's sort of yet up and running. At this point, we make the kits in the United States, and we do quality control here in the US. But I think any of you who really are knowledgeable about off-grid electricity, we really don't want to say that the solar suitcase is the only solution. It is a solution, it's a drop in the bucket, but there are hundreds and thousands of health facilities that have needs, and there are a lot of very bright people here who are thinking of other ways for clinics to access electricity. I actually do a lot of advocacy work. I work with something at the UN Foundation called Sustainable Energy for All movement. Maybe some of you are involved with that. We need everybody's ideas to really address the issues of the 1.6 billion who are without reliable electricity. So we're happy to join with people who would like to work with us, and we actually are very happy to encourage anyone else with their own programs to just take them and run with them. And we're happy to share a lot of the challenges that we face because, as Ben was mentioning, distribution is really hard, and then servicing things that they are really hard. So I think all of us need to work together to really help to solve the problem of energy poverty.
Great. So thank you so much. I have a couple of lovely, you guys have seen these. So these are indestructible lights. And if you're here, for those of you who haven't seen me demo these are fun. You press this little button here, and they have a bunch of different sizes. And this was actually made and designed by Ken Duker, if any of you went and visited the truck this afternoon. And he spent a lot of time wiring these by hand before he got a model down that you could run over with trucks, throw in water, get eaten by bears, maybe 5-year-old children not, but other than that. So I've used these a lot in my disaster response, and because this is all about humanitarian use, there you go.
Also, we do have a solar suitcase in the back of the room, so if anybody is interested in seeing it, we're happy to show it.
All right. Thank you so much.